Ivan, ID physician from Peter Mac here, introducing Julian Lindsay, who's a PhD candidate at the National Centre for Infections in Cancer, a bone marrow transplant pharmacist who's been researching infection in BMT or allogeneic stem cell transplant patients, and he'll be presenting now. Thanks, Julian.
Thank you very much, Monica, and thanks everyone for dialing in early in the morning. So today I wanted to talk to everyone about the infection-related mortality of allo transplant in Australia and give a broad overview of what's been happening over the last few years. And then at the end of that talk, that should only go for sort of 15 or 20 minutes, I just wanted to talk to everyone about what projects I'm working on with the NCIC to try and improve this infection-related mortality. So thank you for the introduction. As Monica said, I'm a pharmacist at North Shore Hospital, which I've briefly put on hold as I do the PhD full-time with the NCIC, as well as the Fred Hutch Cancer Research Centre in Seattle. Just to figure out how to, there we go. So just as most people know what an allogeneic stem cell transplant is, but just in case there's those in the audience that don't do allos at their centre, allogeneic stem cell transplantation is a very high risk, highly immune suppressive treatment for hematological malignancies. It involves collecting stem cells, the progenitors, from healthy donors. And then in the patient with the hematological malignancy or blood cancer, we give huge doses of chemotherapy to wipe out their marrow and all of their hematopoietic stem cells. We then infuse the stem cells of the healthy donor into that patient, which will eventually then totally transplant the patient, the donor's blood cells into the patient. The reasons that this is such a highly immune suppressive treatment and infection is such a big part of the patient's journey is the huge doses of chemotherapy or radiotherapy that are required to irreversibly knock out all of the stem cells and all of the bone marrow in the patient. And then we also need to use further immune suppression, initially partly to prevent the rejection of the stem cells that we're putting into the patient, but largely because we need to prevent graft versus host disease. And for those of you that don't know what that is, that's when the donor's blood cells will grow in the new patient and will replace their blood system. But their immune system, when they grow, the T cell and B cells, mostly T cells, recognize the patient as foreign, just like a solid organ transplant. The patient's immune system would recognize it as foreign, except this could be any organ of the body. And that is what we call graft versus host disease. And it's quite a significant problem in patients because you can't suppress them too much, otherwise they will succumb to an infection or they will relapse because those new T cells that we have transplanted into patients are also a lifelong cure for any relapse that happens. And that's why we do it. It's a very high risk and very intense procedure, but it provides a cure for many otherwise incurable malignancies like high risk AML and ALL. So the good thing about allogeneic transplantation is that we use an international donor registry to get, if patients don't have a related donor, then we go to an international registry, and this is a registry that's international. Almost every allo centre in the world is part of this Centre for International Bone Marrow Transplant Registry, and all of the outcomes are reported back to the CIBMTR. So having a look at infection as a mortality overall over time, if you have a look on the left at 2003 to 2008, and this is every allo transplant from this time period that's been reported back to the international registry, so we're talking about tens of thousands of transplants. The primary reason for death at day 100 is relapse of their primary disease at 35%. Graft versus host disease, about 12% of people, and you'll notice the infection is at about 17%. So fast forward a decade to the most recent data that we have, which is around 2015-16, and you'll notice that we're much better at preventing death from relapsing of their primary disease. That's gone from 35% down to 20%. However, infection has actually marginally gone up. And also graft versus host disease has marginally gone down. And this could be due to less people dying and us getting better, but it's actually not. Both from a decade ago and now, there's about a 10% mortality at day 100. So we're still talking about a significant number of patients. And if you think about all of the anti-infectives and protocols that have come to market from 2003 to 2015, you would think this number would be a lot less. So what we wanted to do, and to give you an idea of what those infections are, there's a paper from EBMT, which is the EBMT infection-related mortality, and this is getting quite old. It's from 2005, but there hasn't really been anything since with such good patient numbers. There's 14,000 patients. Every infection-related mortality was well documented as to what was the causative agent for that infection-related death. And you can see that about a third of bacterial, a third of viral, and a third of fungal, with a small amount of parasitic infection deaths as well. So what we really wanted to do is investigate the infection-related mortality in patients in Australia to see if we could find any better detail. And we did this by contacting the Australasian Bone Marrow Transplant Registry. And this reports to the CIBMTR, but they're Australia, New Zealand, and Asia. And so and all Australian transplant centres, it's mandatory that they report all of their outcomes to the ABMTRR. So we requested an audit to look at every consecutive first allogeneic transplant from 2013 to 17. So we had full data sets for the entire time, because there is a bit of a lag with reporting. And we collected all the data on mortality, demographics, and transplant details. The all-cause mortality we split into primary disease. So if anyone had relapsed and then died after relapse, that was considered a primary disease mortality. Patients that have died of infection only, patients that have died of graft versus host disease only. And then we also had a category that hasn't really been reported for, but we thought it was an important factor, which is looking at when infection and graft versus host disease was checked as the cause of mortality. And the reason for that is when graft versus host disease occurs, it's not the type of disease where only 10% of people get it, and when you get it, it's very bad. In fact, over half of patients will have graft versus host disease to some degree, because it just means they have a very active, healthy graft. And we immune suppress that with steroids and other immune suppressive agents. Often when we do that, we then put them at risk of an opportunistic infection. So we wanted to capture what patients were dying of an infection when they had graft versus host disease. And then we also, anything else was classified as other. So the results, there were 2,777 first allogeneic transplants in Australia in that 5-year period. So if you work at a transplant centre and you looked after a patient between 2013 and 17, then their data is here. About half of the patients were MUDs and about 40% were SIBs. And if you're wondering what that is, a MUD is a matched unrelated donor, and that's where they didn't have a matched sibling that we could get stem cells off. And so we have requested stem cells from somewhere in the world from an unrelated donor. The reason that's important is because we often give them a little bit more immune suppression, because they're a little bit higher risk of graft versus host disease, because the match of their stem cells is not quite as good as a match of a sibling. The median age was 45 years, and the majority of patients, the reason for transplant was acute myeloid leukemia, 20% acute lymphoblastic leukemia, and then about 10% MDS and non-Hodgkin lymphoma. So overall, the deaths at day 100, there were 268 deaths, and this is 9.65%, which is almost exactly what the CIBMTR would report. So we're sort of in the same ballpark as the rest of the world as far as the number of patients that die at day 100. And likewise, we're pretty much in the same ballpark with 24% of patients dying at 1 year. So when I say it's a high-risk procedure, it is a very quite high-risk procedure with 1/4 of patients not surviving the first year post-transplant. So having a look at what the causes of death were, going back to day 100, all-cause mortality. So this is 268 of the 2,700 patients that were transplanted in Australia. At day 100, almost half, 46% of patients died of an infection. Disease progression was only 10.4%. So we're doing very well at not putting people to transplant if they are in an active progressive disease. We get them in a good disease control before going to transplant. Graft versus host disease is still quite high at 13%, and then infection and graft versus host disease was 10%. So at 1 year post-transplant, 24% of patients have succumbed, and of that, disease progression does increase. And so at 1 year, 36% of patients have 36% of the 25% overall, so 36% of the deaths were because of disease progression. Infection alone is almost 30%, and infection plus graft versus host disease is 9%. And I think the really important thing to note here is that if you combine infection plus graft versus host and infection alone to make up any infection-related mortality, this is 37.7%, which is actually higher than disease progression. So you could get out of this data that infectious-related death is the highest cause of death post-transplant at 1 year. And I think this is the best slide of the talk. It's really good at showing what these deaths were over time. So this is the cumulative incidence of death as an overall proportion of patients, not of deaths, but of patients, and the days post-transplant down the side. And you can see, so this is day 100 and it finishes at 1 year post. Relapse is red, and you can see that early on, not many people relapse. So we're not putting people straight into a transplant when they're still in a disease progression and they just progress through the transplant and die. There's a very low rate. However, at about day 100, that really takes off and it escalates to eventually be the highest cause of death at 1 year. But then you can see infection straight from day 0, especially a very rapid rise up to day 30. And this is when patients will be neutropenic. They'll be at their most sick. This is when most of the deaths occur from infection, but it also steadily rises from day 100, continuing to go up to be at about that 7% of all deaths at 1 year. Other is just a steady rise over time, starting to reduce as time goes on. Graft versus host disease has absolutely no deaths up until about day 30, and that makes sense because you can't develop graft versus host disease until those stem cells that you have infused, have engrafted, have made T and B cells and then started attacking the body. So you don't see any deaths related to graft versus host disease early, but eventually around day 30, this picks up and increases. And with that, graft versus host plus infection starts to pick up. We did look at mortality over time, just for the 5-year period that we looked at, and there was no real trend in infection increasing or whatnot, but it's not really the right time frame to try to be looking at trends anyway, so that was not too much of a surprise. We did, however, look at deaths of MUDs and SIBs, and there were two significantly different results, and that was in infection. So matched unrelated donors have a much higher risk of dying of infection at 1 year compared to siblings. And that's, again, unsurprising because you give immune suppression to matched unrelated donors to prevent graft versus host disease. But it's also important to keep in mind that, perhaps we could be giving more infection prevention strategies for those people to try and get them into similar positions. And also graft versus host disease, unsurprisingly, MUDs had a higher chance of death over siblings. So that was 3.7% of patients, first 2.1 will die at 1 year. The other disease progression and other, there were not significant differences in the numbers. So how did we compare to the rest of the world, even though we are included in this CIBMTR data? Now, this seems very different, but I want to sort of stress that there are very different categorical reporting differences between registries. So you have to take this with a grain of salt. And I'm not saying that our infection-related mortality is twice as bad as the rest of the world. In some places, they mightn't have the same diagnostic criteria to be able to diagnose infections, and they might report that as just organ failure. And also, there's just a lot of differences with registry data. However, there's clearly a trend that in Australia at day 100, a lot of our deaths are infection related, with 46% compared to the 21% reported in the rest of the world. Clearly, disease progression is better, and other areas are similar. Now, there is some really interesting data in the registry data. However, because it's registry data, it's not perfect. So essentially, when the transplant centers are collecting this data, they check boxes for mortality into things like infection, and then there's a separate column to write in what that infection was. Unfortunately, only about 50% of the patients had this extra optional area filled out. So we only really have the details of about 50% of the deaths out of the 256 deaths in Australia to find what infection it actually was. So this is definitely not overall, but what I like to think of it is there were at least. So it could have been double this number, but we don't know that. But for cause of death, there were at least 25 fungal deaths, and this included 4 Aspergillus, 3 Scedosporium or Lamentaspora, Candida glabrata and Fusarium. There were 20 bacterial infections, of which half of those were Pseudomonas. 11 CMV deaths, most of them were CMV pneumonitis. There were 6 EBV PTLD deaths, and that's actually quite a problem in Australia that's starting to become prevalent, and we'll get onto that in a little bit further. And there were actually 5 adenovirus infectious deaths. Now, like I said, it could be double or triple this, but we just don't have that data reported into the registry. So what we got from this study was that infection is a major cause of mortality in allotransplanting, accounting for almost half of the deaths at day 100 and almost 30% of the deaths at 1 year. Matched unrelated donors have a higher risk of infection-related deaths, and there's definitely room for further research and development of infection prevention strategies in this population. And so just for the last sort of 10 minutes of my talk, I just wanted to talk about some of the projects that I'm running with the National Centre for Infection and Cancer to try and prevent some of these infectious deaths in bone marrow transplantation, just so you have a picture of what's going on in Australia. So my thesis is on 3 separate areas, which is very broad, which is covering cytomegalovirus or CMV infectious deaths, post-transplant lymphoproliferative disorder caused by Epstein-Barr virus, and a heavy focus is on invasive fungal infections. So what have we done with CMV? So this was the first area we looked at, and I actually led a retrospective study at our centre at North Shore Hospital in Sydney. Dr. Michelle Yong is expanding this study and running the CREST study in Australia. So there's a lot of bigger numbers to come in the next year or so. So definitely something to look out for that. But often it's good just doing one site because we use a set protocol for our prevention strategies. And so it's a good idea to look at your own centre for exactly what the risk and the problems are. And we found a very clear risk group of patients that developed a CMV infection. So the graph on the left, this is clinically significant CMV infection. And what I mean by that is we watch and wait until the CMV level hits 1,000 international units per mil before giving preemptive therapy for CMV with ganciclovir or valganciclovir, or foscarnet if they're neutropenic. And we split the risk groups into either matched related donors, so this would be another name for sibling, or unrelated donor, so that's another name for MUD. And we split the groups into their CMV serostatus of their donor and of the recipient. So what this means is that, for example, this group that is a very, very high risk of reactivating. So by day 50, almost 80% of the donor negative recipient positive unrelated donor group had reactivated their CMV, clinically significantly reactivated, needing treatment. So this means that the stem cells from the donor were seronegative. They had never been exposed to CMV and they did not have any CMV antibodies present, which you get some immunity from when you get those stem cells given to you or to the patient. However, the patient was positive for CMV, so they had been exposed to CMV in the past. If both are negative, we don't even check for CMV. It's a very, very, very low rate of reactivation if the donor is negative and the patient's negative. So you can clearly see that, that there's a much higher rate of reactivation at about 70% versus 30 to 40% for any other combination, whether it's an unrelated donor with positive recipient and positive donor, or whether it's a matched related donor. And this actually translated into overall survival, with that patient group of donor negative, recipient positive, unrelated donor doing much worse at 1 year at a survival of about 50% versus the other groups at about 80%. And so we have already implemented using letermovir in all donor negative, recipient positive, unrelated donors at our centre to try and get that number down and try and get that number up. And we'll follow that in a few years to see if that made a difference. And I know a lot of other centres are also doing the same. The other thing we found, we waited till 1,000 before treating, but we actually looked at the tempo of who actually spontaneously cleared without treatment at levels of 56 to 137, 138 to 250, and so on as you go up. And we actually found that no one that went above 350 international units actually then spontaneously cleared without the use of ganciclovir. Everyone escalated up to 1,000 and required treatment. So following that, we're going to change our protocol to treat patients, instead of waiting till their CMV titer reaches 1,000, probably starting to treat them at lower levels of about 350. So just for I have another 5 minutes. So I just want to jump through EBV PTLD. So Epstein-Barr virus related post-transplant lymphoproliferative disorder is quite a niche infection-related morbidity that occurs in transplants. Epstein-Barr virus, or mono, lives in B cells, and when you suppress T cells in an immune-suppressed patient, essentially those Epstein-Barr virus can make the B cells proliferate and take off and become a lymphoma. And it's quite a rare disease, but it's becoming more and more prevalent in transplantation in Australia. And you can see over time, this is data from the ABMTRR, and this is not reported very well. So I'd say the numbers are actually much higher than this, but the numbers are increasingly going up over the last few years. And the main reason for this is because around 2013, most Australian centres started using anti-thymocyte-globulin, or ATG, in all matched unrelated donors to prevent graft versus host disease. And what this does is it just directly inhibits T cells through anti-T cell antibodies. And that's increased the number of EBV PTLDs, which we actually saw in that ABMTRR mortality, with 6 patients from 2013 to 17 dying of EBV PTLD. And so the second study we're doing is a retrospective study from both North Shore and Royal Melbourne, looking at all EBV viral loads and how they predict post-transplant lymphoproliferative disorder. I mean, this is known in the literature, but things that aren't known are the exact levels to preemptively treat that EBV rise with rituximab, or to perhaps prophylactically give rituximab with conditioning. So we should have that data analysed and reported by the end of the year. In the meantime, we've also got together and put together a review of the literature as to which EBV post-transplant lymphoproliferative disorder strategies are used in allogeneic stem cell transplant. And if you work in an allo centre and there isn't, especially if you're using ATG and you don't have a specific guideline, it might be a useful resource for you to look at to see if you could standardise at your centre how you prevent EBV PTLD. So lastly, I just want to talk about what we're doing with fungal infections. So the first sub-study is using suba-itraconazole, which is the new formulation of itraconazole. I think the brand name's Lozanoc here in Australia. And this is a reformulation to improve the absorption. So it has a matrix around it so that it bypasses the stomach and is absorbed in alkaline conditions instead of acidic conditions, which the old formulation was. We've been using suba-itraconazole in every allo stem cell transplant, no matter what risk. Over the last few years, so 131 patients, and across the harbour at Royal Prince Alfred, they've also been doing the same. So we have a cohort of about 200 patients that we're currently analysing right now. So we are looking at analysing and publishing the fungal-free survival of using this new formulation for allotransplant prophylaxis, reporting the breakthrough fungal rates, as well as pharmacokinetic data about therapeutic level attainment and the safety of using it in patients. So that's something that should be published by the end of the year, so something to look out for. And the other two studies I'm working with the Fred Hutch over in Seattle. The first one is a retrospective study looking into infective fungal rates and choice of prophylaxis using an induction protocol called GCLAM. So a few years ago, instead of 7-3 induction for AML, they started using this protocol called GCLAM, which consists of cladribine, mitoxantrone, and a HiDAC up front instead of 7-3. And it's been shown to be quite effective for AML. However, there's a much longer period of neutropenia and fungal infections seem to be a high problem. So I'm working with them on classifying what that risk of infection or specifically a fungal infection is when using this. And then the last study that we're going to be working on that we're putting together right now is a prospective study. They use a lot of voriconazole there. It's a very large center over in Seattle. And we're going to be looking at prospectively doing rapid CYP2C19 genotyping at the time of initiation of voriconazole, and then using a dosing guideline based on their polymorphism as to what dose or alternate drug they will receive, looking at outcomes and time to therapeutic drug levels if using this strategy to try and standardize using pharmacogenomics in voriconazole dosing. And then very lastly, we've also put together a review of new targeted therapies and azole antifungals. And if you find that you're using a lot of these new heme drugs, CAR-Ts, blinatumomab, venetoclax, ibrutinib, midostaurin, we've just put together a bit of a literature review of suggested approaches for invasive fungal disease, and also what dose modifications and dosing of both the heme drug as well as the azole, if you're using these agents. So that's a possible useful guideline that you might want to look at. And that's all. Thank you very much to the ABMTRR for helping out with the audit, Leonie, Steve, and Ian. And thank you very much to my supervisors, Monica, Sharon, David, Matthew, Steve, and Catherine. And I don't know if it's possible to have any questions, but feel free to have any questions. I think there's 1 or 2 minutes left.
Thanks very much, Julian. Arjun, do we have time for 1 or 2 questions?
Yeah, sure. Thank you, Julian. Perfect. We have time for a couple of questions if you'd like. And we have a comment from one of our attendees, who's Charlene, and she says it's a very interesting study.
Thank you. I'm interested to get the results to everyone.
So Julian, it's Kaz here. We do have quite a lot of pharmacists online listening. So from your experience doing your PhD and studying these infections and antifungals, what are your, this is obviously a highly specialised area, lots of acronyms, but takeaway messages to general AMS pharmacists having to come in and perhaps be asked to audit or look at these very high-risk patient groups. What's your takeaway messages?
I think that Transplantation is quite a complicated area with lots of acronyms, but it's also a very standardized area. Every patient has a lot of time spent on the workup for what protocols they will be using. And I think that most centers either have a very strict protocol, including prophylaxis for CMV, for fungal, PJP. If the centre doesn't have a protocol that goes into the depths of, if they're unrelated, this is what they get. If they're not, this is what they get. It might be worth bringing up with the transplant team that, hey, why don't we put together a CMV protocol that sort of outlines every patient? And then you have, and that protocol can then be guided by the literature. You can have a piece of paper with a protocol that you know the patient should be getting to be following. And that protocol does change over time when patients develop graft versus host disease. You know, there's good evidence to change that antifungal prophylaxis from itra to posaconazole. But I feel like sometimes if there's not a protocol for something and it's based on clinician choice, things can get missed, and it's very hard to other people to pick up what's getting missed, where I feel like we should be following protocols. And that way we can do the nuances like therapeutic drug monitoring and interactions, rather than wondering about what the ideal treatment is for that patient. And I think that's very simple for viral and fungal prophylaxis. I think antibacterial treatment, whether that's preemptive, empiric, coming up with a protocol for an individual patient is a little bit more difficult. But I find like I have updated a lot of the protocols since I've been at North Shore. I mean, I've been here for sort of 7 years now, but I feel like as the literature changes, the protocol should be updated, and then everyone has that and knows what every patient should be getting. And I feel like that's probably has been the most beneficial thing, so that AMS can look at it and go, okay, they've developed GVHD, they should be on POSA, let's check the levels are correct. Their CMV levels hit 1,000, they should be on ganciclovir, let's check that that's happened. So that's where I feel like is the most beneficial thing. And be involved with the protocol writing, with the transplant team. I feel like the relationships and everyone can see what they can get out of collaborating if it's a collaborative protocol. Yeah, I feel like that's probably the best thing you could be doing.
That's a fantastic answer, Julian. Thank you.
Well, thanks so much, Julian, for presenting your work. And I'll hand over to Kaz now, who will introduce the second speaker. But very impressive. Thanks, Julian.
Thank you. You're welcome.
So I'm going to introduce Jake Valentine to all of you. Some of you might have come across Jake. He's a force unto himself, but he is our PhD fellow based in Melbourne, working with Leon and our team with NCRC. And really, a lot of his work is intensely relevant to a lot of the work that we're doing and looking at management of infections and impact programs on outcomes of patients. So he's looking at how we're applying administrative data, how can we enhance our surveillance across hospitals and jurisdictions to improve patient outcome. So off you go, Jake.
Thanks very much, Kaz. So I trust that you can all see my screen. If not, just give a shout out. Yep, so thanks, Kaz, for the introduction. So my name is Jake Valentine. I'm a third-year PhD candidate here at the National Centre for Infections and Cancer. And the title of my talk today is The Application of ICD10 to Clinical Surveillance and Health Services Research for Infections. And naturally, in this setting, we'll be focusing on the cancer space. So the central premise of my thesis is big data. It all really sort of focuses around these two key words. And one of the main research questions of my thesis is how do we optimize the existing infection surveillance paradigm with the use of big data, and in tandem with the use of other artificial intelligence mechanisms. So my thesis is a mixed methods thesis. So there's not just one overarching project here per se. There are actually many mini projects, if you will, pertaining to this particular research question. Now, the first of which is a very general and broad research question of how do we use big data? Why would we use big data? What are the advantages? What are the disadvantages? Second to that is ICD10 because I think ICD10 is a form of big data. Big data is quite a heterogeneous term. You know, the use and an evaluation of the codes has been an important part of this thesis, and what is the quality of the codes for that purpose. Next to that is the implications, the funding ramifications by using the codes as the sole metric to measure the rates of healthcare associated infections in a cancer case mix. In this particular project, which I'll be talking about later in the talk, really pertains to a new funding mechanism that the federal government and all state and territory governments have implemented right across the board across Australia. Then we'll be looking at big data in general, and towards the end of the thesis, I'm focusing a great deal of attention on the use of data linkage or linked data in tandem with machine learning mechanisms to overall improve the quality of surveillance. Now, for the purpose of this particular presentation, I'll be focusing on two projects. One is the quality of the codes for, in this case, invasive fungal infection surveillance in a pediatric cancer setting. And then we'll be looking at some of those funding ramifications that I alluded to earlier. So now to the first project, which is the quality of ICD10 for IFI surveillance. Now, just a very quick general background introduction. Current methods for IFI surveillance are indeed quite onerous, time-consuming, and actually quite costly. Now, by current methods, what I'm referring to here is the use of clinical case definitions in accordance with EOITC MSG criteria. They've been around for a while, but they are quite an onerous process to actually diagnose and classify patients with IFI in accordance with these particular criteria. So it's been postulated in the literature that we could somehow potentially harmonise ICD10 codes to streamline those methods for IFI surveillance. And ICD10 just broadly speaking, is indeed one of the largest ontologies to classify disease in the world, not just here in Australia, but a great deal of, a large number of developed countries use their own adaptation of ICD10. So there are actually quite a lot of appealing attributes for the codes. But by the flip side, there's also some unappealing attributes, which we'll be getting into in a moment. Now, to give some context, I have used these codes previously in some previously published works to evaluate some epidemiological trends of IFI using the codes in the adult haematology oncology population in Victoria a number of years ago. But more relevant question here is, well, what is the overall sensitivity of the codes? When we talk about quality, we often think about sensitivity, positive predictive values, and those sorts of things. Now, perhaps the most pertinent study in this particular space is a study published by Chang et al. Coming out of the States, who actually put a number figure on the sensitivity for invasive aspergillosis codes. Mind you, these were ICD-9C, and this is the old American adaptation of the codes. But nonetheless, they came to an overall sensitivity of 63% in the adult HCT SOT recipients. So 63% is not crash hot, but it's certainly not dismal either. So we wanted to know, well, how does this fare in Australia? No one has done this in Australia with the use of ICD10 and no one in the world has done this in a pediatric cancer population. So my hypothesis, therefore, was that the classification performance of the codes is suboptimal. That is based on what I've read in the literature and what the general consensus is in the literature as well. So the aims were threefold. First of which was to describe the sensitivity, PPV, or positive predictive value, and the F1 score. F1 may be new to most of you, but I'll be talking about that in a moment. Of the codes for case detection of IFI in the pediatric cancer patients. Then looking at the misclassification rate of ICD10 and lastly, I thought this was quite an interesting one, was to identify the coding abstractions yielding the highest classification estimates. Because I think traditionally, we've often thought about codes in general as an amalgamation set of codes, whereas we don't actually recognize that, for example, even IFI, there's about, I think, 20 different codes. And traditionally in the literature, they've just looked at a composite set. Whereas in this particular study, we're going very, very granular. We're actually evaluating the quality of individual specific codes to see which one gives us the best bang for our buck in terms of overall classification performance. Now, in terms of the methods, there are three fundamental formulae which really did form the basis of this work. So it's quite a mathematical project. Now, sensitivity and PPV, I'm sure most of you are aware. True positives divided by true positives is false negatives, and so on and so forth for PPV. But the F1 score is quite an interesting one because no study in the literature, at least none that I've read, have actually quantified the quality of coding data for surveillance using an F1 score. Now, an F1 score is, it's actually rather simple. It's just simply the harmonic mean of sensitivity and PPV, because let's not forget that SEN and PPV address slightly different questions. Sensitivity is an overall classification estimate, whereas a PPV is a probability estimate. So by bringing them together, we get an overall view of the performance by using by really plugging in the answers from both of those formulae into the F1 formula, giving us an overview of how well the codes fare. Now, in terms of the overall flow of the study, we started off by collecting administrative coding data for all paediatric patients with a cancer diagnosis at the Royal Children's Hospital, spanning 2004 to 2013 from the Victorian Admitted Episodes data set. So there are about 1,600 odd patients there. Now, of those, there are 114 who were in receipt of at least one code denoting IFI, and the remainder had no code denoting IFI. Now, those that did have a code for IFI, I then linked the data to what we call the R-Terrific data set. Now, this is what we treated as our gold standard. Now, this was compiled and procured by Dr. Gabrielle Heusel, my colleague, and her colleagues as well. And in this data set, we have, it's a full data set of all clinically verified physician-adjudicated diagnoses of IFI in accordance with the OITC criteria. So after linking the codes with this gold standard, I was able to identify and enumerate the total number of true positive cases. So of the 114 who did have at least one code, 68 were present in the R-Terrific data set. And of those with no IFI code, there were in fact 45 who were present in the R-Terrific, which in this case comes to our false negative cases. And I could then stratify and slice and dice the data by underlying EORTC classification. But the real take home here is the 68 versus the 45 true pos versus false neg. Now, I could then triangulate that and put that into a 2x2 confusion matrix. So on the top, you've got the gold standard data set. This is our R-Terrific, pos and neg. On the left-hand side, we've got the VAED coding data set, pos and neg as well. Now, you can see here, we've got the 68, which I alluded to earlier, which are the true positives. We have the 45 false negatives, which comes to an overall sensitivity of 60%. Now, that actually corroborates with what we saw on the Chang paper, which was 63%. Mind you, the Chang paper wasn't in the adult setting, this is in the peds. But nonetheless, we are corroborating with international estimates here. Now, by sheer fluke, the denominators were actually very, very, very similar. We had 113 gold standards versus 114 patients assigned the code. So just by the fact that we've got such similar denominators, it turns out that the PPV was also 60% with very slightly different 95% confidence intervals. So therefore, our overarching F1 score also comes to 60%. So I think the take home here is that 60% is not dismal. It's not crash hot either. It's quite moderate in my mind, but it certainly corroborates what we see coming out of the United States. Now, I then sliced and diced those data by underlying IFI. So we've seen the top row here, that's the 60% we saw before, sensitivity, PPV, and F1 score. But if you can actually look at, well, how do the codes fare in terms of the type of IFI that we're actually putting under surveillance? So look at the molds, invasive aspergillosis, these are the B44X codes. Interestingly enough, the sensitivity actually drops. It actually gets quite lower at 42% versus 60% overall. And I think this is where it gets really, really interesting, because the yeast invasive candidiasis, these are B37X codes, it's actually double that of the molds, which I found really, really quite fascinating at 83% overall sensitivity. Now, that's actually quite positive news. And I think having read a lot in this space and literature, I think one of the reasons why that could be the case is that traditionally, broadly speaking here, is that yeast are a lot easier, I suppose, to diagnose than a mold infection, a very complex mold infection. And so when there's a much more confirmatory diagnosis indicating invasive candidiasis, that will more or less be translated quite easily into an ICD10 AIM code, because let's not forget that it's a human clinical coder who has to read that diagnostic information to then assign the code. So that could be one. I'm sure there are many other postulated reasons, but I think that was an interesting find. Now, once again, I slice and dice it in many different ways, and I also wanted to evaluate the performance of the codes according to EORTC MSG criteria. So once again, unsurprisingly, the provens are much better coded with 77% sensitivity than the probables and the possibles. And once again, I think this just speaks to the fact that a proven IFI diagnosis, broadly speaking, it's a far more confirmatory diagnosis. It will be physician adjudicated in a lot of instances, and therefore a clinical coder will have a much easier job to try to interpret that information and say, yep, that is a definite IFI, let's code it as such. Now, I'm going to get you to put your math thinking hats on for a moment, because one of the other aims of this project was looking at, well, which combination or coding abstraction gives us the best bang for our buck in terms of high sensitivity. Now, I'm going to use the example here of invasive aspergillosis, or IA. Now, to give some context here, there are about, I think, 7 or 8 codes denoting invasive aspergillosis. Now, for the purpose of this particular presentation, I'm just going to focus on the nuts and bolts here. So on the left-hand side, we've got a Venn diagram. So here we got B440 and B441. Both codes denote invasive aspergillosis. But I wanted to know which of those specific codes does give us the best overall performance. Now, here we have the probability of a gold standard IA patient being assigned B440, denoted here. And likewise, a gold standard IA patient with a B441, once again, represented mathematically here. Now, the intersect is the probability of a gold standard patient assigned both codes 0 and 1. And we can represent that mathematically with this intersect symbol here. Now, what I've done in this particular analysis is, well, said, what if we treat the codes as a union set? Now, what I mean by union set is looking at what's the probability of a gold standard confirmed mold case being assigned either 0 or 1. So we're really taking this as a union set, and we can represent that mathematically with this union symbol here. Now, if you're looking at the probability of, or the sensitivity rather, of a gold standard patient being assigned either of these codes, we get an overall sensitivity of 37%. Now, that sensitivity increases to 42% when we add another IA code to the mix. And I think mathematically that's rather intuitive. The more you add into the surveillance system, the more likely you are, or the increased probability you get to actually get case ascertainment. But you may notice here that intersect actually diminishes. It's quite large here with 2 codes. It gets even smaller with 3. And that'll be important later on towards the talk. So just bear that in mind. But the take home here is that absolutely the more codes you enter a surveillance system, or the specific codes you enter a surveillance system, the more likely you are to get for case ascertainment. Now, I could actually represent this mathematically. So I've actually used this formula on the top right-hand corner here. And this formula actually enabled me to compute and actually calculate every single type of combination for every single type of IFI under surveillance. So we've got the sensitivity, PPV, and F1 score. So here we have the types of IFI. Now, just for brevity, I've only put the codes in the table that actually gave us highest overall performance. There were many that gave us 0%, but just for the purpose of brevity, I'm just going to focus on the ones that gave us the best bang for our buck. So if you're looking at just the performance of B440 for IA, we have an overall sensitivity of 11%. You have 0 or 1, 37%. We saw that earlier. You add another code to the mix, you get 42%. So the take home here is that the sensitivity increases the more codes you add to the surveillance system. And interestingly enough, we saw the same for invasive candidiasis, B377 at a 43%, 3788, 53%, and that goes up to a whopping 83% when you combine both of those codes together. So we're not saying that a patient has both of those codes necessarily, it's saying that they have one or the other. And the same goes for other unspecified IFI. Now that and versus or Boolean actually becomes quite important here. So once again, mathematically, we can represent that with the or symbol or the and symbol. Now, if we're looking at developing a surveillance system with using codes, and you want to say, well, what is the probability of identifying a true positive case if a patient has 2 or more codes? So 3 codes, 4 codes, et cetera, et cetera. Well, in actual fact, the sensitivity diminishes when you apply those sorts of definitions to your surveillance system. And I'll represent that here mathematically. So here we have a Venn diagram. It's a rather unusual Venn diagram, but the outer circle here is the number of patients who are assigned at least 1 code for IFI. Now, patients who have at least 2, so 2 or more codes, mathematically speaking, is a subset of those with 1, or at least 1. And then patients with 3 codes is a subset of those who have at least 2 codes, who have at least, which is a subset of those who have at least 1 code. So we are getting quite mathematical, but it's very important because we can represent that mathematically at the top here. But the take home here is the fact that the case definitions become they become increasingly specific when you stipulate in your surveillance system that I want patients with 3, 2, or 3, 4, 5, et cetera, codes. And the reason for that is we just go back to the basics 101, right? Is sensitivity is calculated. We know it's calculated as the true positives divided by gold standard cases. Now, based on this fact that we've got a subset of a subset of a subset, your true positives will diminish. They'll get smaller and smaller and smaller. So your numerator decreases whilst your gold standard cases don't change because that's just how many gold standard cases you have. So naturally your sensitivity will decrease. And I actually demonstrated that in this particular study. So once again, looking at our invasive aspergillosis example, I've demonstrated that the sensitivity actually decreases. So we saw before that B440 yields a sensitivity of 11% for case ascertainment. If you have a surveillance system that says we need to have a patient with 0 and 1, well, that only came to 5.26%. Because we had such few patients who actually had that. And then if you have 0, 1 and 7, you get 0% because simply no patient, at least in this particular study, was assigned 3 codes for mold infection. And really just generally speaking, the chance of a patient being assigned numerous IFI codes for the same episode of care is actually rather slim, just in general terms there. Now, another one of the aims was looking at the misclassification rate. Now, what I mean by that is, and once again, very few studies, if any, have actually quantified this, was looking at, well, in this particular example, what we're saying here is that 13% of gold standard IA cases, invasive aspergillosis cases, were coded as IC. So they were assigned an IFI code, but it was the wrong one. And the same, and the inverse is also true, whereby we have 9.52% of IC cases coded as IA. So the take-home message is here is that ICD10, when used in isolation, is an unreliable metric to detect IFI. We had an overall pooled sensitivity for 60%. So it's not really that good. However, and I think this is probably one of the highlights from this particular work, was that the B37X codes, which are the invasive candidiasis codes, may indeed actually be a feasible proxy to signal medical record review of possible yeast infections, given those high classification estimates. Now, the reason I say that is because if indeed we have a suspected invasive candidiasis infection, we're not too sure if it actually is one, but the medical charts are indicating, well, we actually have a code for it. Maybe we should do a deeper dive and actually confirm that is a true yeast infection. So this is where the B37X codes may possibly have some value and have some benefit. Now, we've also demonstrated in this study that the accuracy does depend on the type of IFI under surveillance. Yeasts are generally speaking better coded than molds. The certainty of diagnosis has a very important role to play. Provens are better coded than probables and possibles. And the coding instructions also matter because some codes gave us a 0% sensitivity. Others, when used in combination, gave us far higher. But if I may touch on this particular point, I think this is an important one to make because very few studies have also highlighted this, was that there is a disconnect between Australian coding standards and EU ITC MSG criteria. Now, what I mean by that is it's like speaking 2 different languages here. You know, you've got coders speaking in dog language and, you know, a clinician speaking in cat language almost. So they might be able to speak amongst themselves in their own language, but not necessarily with one another. Because let's not forget that clinical coders must adhere to very, very rigid, very strict coding guidelines. And those coding guidelines don't necessarily match one-to-one with how a clinician may diagnose an invasive fungal infection. So I think these are other things to bear in mind. These classification estimates might not just be due to chance or due to erroneous coding. In some instances they may be. But I think more to the point, this is more likely due to the fact that we do have a significant methodological disconnect between these 2 types of medical lexicon. Now, we're going to shift gears here now to the second study, which is looking at HAC funding in a cancer case mix. And what do I mean by HAC? So HAC stands for hospital-acquired complication. Now, this is a policy, a federal policy it was endorsed in a COAG meeting, I think in 2016. And the federal government, along with all state and territory governments, have now put in place this new modification to how hospitals are funded right across the country. Now, how it works, or what it's intended to do rather, is to act as a financial disincentive to encourage healthcare facilities to reduce the frequency of HACs. Now, included in that HAC terminology are infections. So healthcare-associated infections do fall under that classification. Now, what I mean by financial disincentive is that what will happen here is that if an ICD10 code denoting a particular infection is reported to the government from any given hospital, the government will actually then withhold a percentage of their healthcare funding, in our case in Victoria, and that's WEIS, to that hospital to almost act as a financial disincentive. So in other words, the hospital will still receive a percentage of their overall healthcare funding, but they won't get the full amount. So there is significant funding loss likely coming out of this particular funding model. So it's been in place since July 2018. And to give some context of why it was implemented in the first place, in the 2017-18 financial year, HACs actually cost the Australian taxpayer $4.1 billion in healthcare expenditure, which actually equated to 8.9% of the Commonwealth's healthcare budget at the time. So they are extremely costly, and that is why the federal government, along with their state and territory colleagues, actually sort of wanted to frame something new and try to reduce them from occurring in the first place. So in very layman's simple terms, the more HACs you report, the less funding you get. It's as simple as that. But how does it really work? So to give some context here, so this is pre-HAC policy now. So once upon a time, we'd have a patient with no healthcare associated infection. All of his medical information will be reported in the EMR, at least it will now in a lot of hospitals. And that will be translated into corresponding codes, and that hospital will receive the adequate level of funding reimbursement. Conversely, however, is that if that patient receive or sadly acquired a healthcare associated infection, then they'll still receive the same codes, they'll be assigned the same codes, but now they'll also be assigned an infection code. And before the HAC policy was in play, believe it or not, that hospital would actually receive additional funding in order to basically reflect the fact that there is increased expenditure typically going on to manage the infection. So therefore the hospital warrants that addition in healthcare funding to sort of balance out the budget. But now that's all going to change now with the HAC in play. So with the HAC, in the same instance, that hospital would receive a significant reduction in healthcare funding as opposed to before. But this is where my study comes in, is that when we have a HAC plus a cancer patient or a cancer case mix in general, we know based on the literature, we know based on even on clinical experience that patients with cancer are significantly immunosuppressed, which increases their risk for acquiring certain types of HACs. So if we know that generally speaking, we get more HACs occurring, we're going to have more of these codes being reported, it's very, very, very likely that we're going to get even larger reductions in healthcare funding in a cancer case mix. So we need to ensure that this particular health policy is equitable, it is sustainable, particularly for hospitals managing large numbers or large cancer case mix. And I think that Peter Mac is the exemplar in that particular instance. So with respect to the policy, there are 16 classifications of HACs. There are many different types of complications, but the third one is obviously of most interest here. This is the healthcare associated infections, of which there are 8 types under monitoring. Now, for this particular work, I'll be focusing on those in aqua. So the aims of this work, one of which was to conduct a retrospective chart review of all HACO3 coded episodes at the Peter MacCallum over a 2-year time span. Second of which was to then simulate the Independent Hospital Pricing Authority's negative funding adjustment on concordant and discordant coded admissions at the PMCC. And I think I forgot to mention there that the Independent Hospital Pricing Authority was the national body whose job it was to actually develop those funding adjustment algorithms. So the government actually went to the IPA and said, listen, we want you to put this together, go ahead and do it. And that's what they did. So I want to actually simulate their risk adjustment model on a cancer case mix and see and actually quantify what the funding loss will be for high-risk patients with cancer. So how this study went about, so I identified all of those patients in receipt of the code. I then conducted my chart review by applying consensus surveillance definitions for specific discrete healthcare associated infections to determine if those patients with a HAC code truly were healthcare associated according to surveillance criteria and surveillance definitions. So after doing my chart review, I then had my concordant and discordantly coded groups. So concordant are those patients who had a HAC code and that did marry or did satisfy surveillance definitions, and the discordant was the opposite. So we had a code that really, as per my chart review, was not a healthcare associated event. And after doing that, I then conducted my primary cost analysis, which was to calculate the WEASE payments on a per episode basis. And I used the WEASE payments by using the Victorian government's WEASE formula. And after calculating the amount claimed in WEASE payments, I could then conduct my secondary cost analysis, which was to actually simulate the Independent Hospital Pricing Authority's negative funding adjustment algorithm on those WEASE payments to actually quantify the reduction in healthcare funding for both the concordant and discordantly coded groups. Now, in terms of performance, that was measured in PPV, positive predicted value. Just more of an FYI, I adapted my criteria from the American CDC and NHSN and more locally from the Australian Commission. And between 2015 to 2017, there were 420 HACO3 coded episodes at the Peter MacCallum, of which 161, as per my chart review, actually satisfied surveillance criteria in accordance with these 2 listed above, which comes to an overall PPV of 38%. So it's not very good. It's not terrible, but it's certainly not great. Now I could then stratify that by the type of HAC under surveillance here, and the take-home message here is that pneumonia HAC 3.3 was very poorly coded at 13%, and that was quite a shocking surprise to me. But and I'll get to why that is now. So reasons for discordant coding was very important. So as I was doing my chart review, I was actually taking note of why we may be getting discordant coding. And you can see that in this bar chart here. But the most important point to take from this is what's listed on the right-hand side, those 5 key points. So one of the main reasons why we had discordant coding was that often we had an infection diagnosed in an earlier admission, but it was coded in a subsequent hospitalisation. And I think this speaks to another important fact about using coding for surveillance is that typically it's not in real time. So on average, there's about a 1-month lag for an infection to be coded. So if you are thinking about using codes for that purpose, yeah, just be cautious at that point. Secondly, is that insufficient information was often there, so we didn't have enough information to actually classify something as truly healthcare associated in accordance with surveillance criteria. Thirdly, was that we often had a positive micro result for normal flora. We had no indication for infection, but there was a positive micro result indicating a normal flora, but the clinical coder may have misinterpreted that as an infection. Fourthly, often we just had the wrong infection was coded. And I think this speaks now to that 13% pneumonia PPV we saw before, was that often and once again, this is another disconnect I've noted in my research, is that there appears to be a disconnect between a clinician diagnosed pneumonia versus a surveillance diagnosed pneumonia per se. So I think once again, a physician may use a whole suite of clinical acumen and the works to diagnose a patient with hospital acquired pneumonia, whereas once again, those definitions and those interpretations may not, and they do not often meet eye to eye, one to one with how with consensus surveillance criteria for healthcare associated events. So often we had in a lot of cases it was documented, it was quite black and white in the discharge summary that we had a hospital acquired pneumonia. But sadly, it just, and therefore it'd be coded as such. But sadly, it just did not satisfy those criteria, the surveillance criteria, that is. Now to the crunch of this particular analysis was what does this mean for healthcare funding? So what we're looking at here is a bar chart on the left hand. On the y-axis, we're looking at the mean or the average waste payments on a per episode basis. And then I've stratified that by the types of PACs which I focused on. Now the blue bars here are the concordantly coded episodes, and the red are the discordantly coded episodes. Now on the leftmost bar is how much was claimed in waste on a per episode basis before application of the negative funding adjustment, and on the right is how much was claimed after the adjustment. So naturally, you would see a decrement, would see an overall percent decrement. And the same goes for the discordantly coded groups. Now, if we take a bird's eye view, so if we just think of the codes as an amalgamation set, so forget the discordant versus concordant, on a per episode basis, we would, this is all hypothetical, mind you, this is before HAC policy was in play, but we're just trying to highlight the point here. So before the HAC policy was in play, we noted that we would hypothetically lose $1,300 for every single hospitalisation because a HAC code was reported. And over the span of a 2-year financial period, that would equate to $920,000 loss in withheld waste payments at a single hospital due to the fact that we're reporting these codes to the government. So there are, which nearly is $1 million. So that is quite significant. And I think if you think about, I think health services research more broadly, I think this is another really interesting space, is not just to evaluate the quality of new guidelines and those sorts of things in healthcare, but to also evaluate policy. I think policy evaluation is really, really important here. And after stratifying that by concordant versus discordant, we can see here that the concordantly coded group did in fact accrue higher withheld waste payments at $1,800 per episode, as opposed to the discordant, which is about $1,100 in withheld waste payments per episode. So I'll finish up there by some take homes. So lastly, discordant coding is associated with about $1,100 reduction in per episode waste payments, and that's just at a single hospital and cancer case mix. And I think in my mind, and I'm thinking out loud here, is that I think a targeted approach is required to mitigate this kind of erroneous coding. Now, two postulated reasons or methods to do that could be regular liaison between clinical coders and infection prevention staff or infectious disease staff, just to ensure that if we do have a suspected or diagnosis of an infection, that a clinical coder is privy to ensuring that actually truly meets surveillance criteria. And I think lastly is just once again a little bit like with what we saw with the Australian coding standards in the IFI study, is that maybe it might be worthwhile to think about how we harmonise CDC and HSN surveillance criteria, and even those criteria adapted from the Australian Commission with Australian coding standards, once again to ensure that we are going to mitigate and circumvent any lost any discordant coding, and therefore any lost funding opportunity. So I'm going to leave it there. Thank you very much for your time, and certainly I think I may have gone just over time, but I'm open to any questions as well. So thank you very much.
Jake, we might have gone a little bit too far over to take questions this morning, but please feel free to contact us. We will be putting these presentations onto the NCRC and the NCAS website as well. Thank you both, Julian and Jake, for presenting this morning. It's just fascinating work.
Thank you very much, Kaz.
Thank you both. Thanks, Julian and Jake.
Thanks.
Thanks for dialing in.